Welcome to the deep dive. Okay, if you're an occupational therapy student and you're heading into your level 2 field work, maybe especially in hand therapy, well, you probably already know the clinical environment is a whole different world compared to the classroom. So our mission today really is to cut through some of that initial, overwhelm. We want to equip you with some really actionable insights. We're going to take a practical deep dive into orthopedic conditions, hand impairments, things like rheumatoid arthritis, osteoarthritis, looking at them through the lens of assessment, diagnosis, and intervention. Think of this as your shortcut, helping you hit the ground running, make a real difference during your rotation.
Exactly. And we're not just, listing facts off the page. Our goal is to really illuminate not just what you'll be doing in the clinic, but crucially, why. Why are certain assessments chosen? Why those specific interventions? And why truly getting these foundational pieces is just so vital for making that jump from theory in the classroom to, effective clinical practice. We want you to understand the thinking behind it all, that deeper grasp.
Yeah. Okay, so let's get right down to it. For entry-level OT students stepping into orthopedics, what's the fundamental thing we need to keep front and center? What's the big picture? The main objective?
Yeah, the main purpose, looking at our sources, it's really clear. It's all about helping clients achieve maximal musculoskeletal functioning.
Yeah.
Why? So they can fully engage in their everyday activities, their occupations, what matters to them.
Getting them back to doing what they need and want to do.
Precisely. And this purpose, it actually looks quite different depending on the stage. Are you dealing with an acute injury, or is it more of a chronic, long-term thing?
Ah, okay. So break that down. Acute versus chronic.
Right. So in the acute stage, think, right after a fracture, maybe post-surgery, your immediate job as an OT is focused. It's about pain relief, getting swelling down, maybe helping with wound care, making sure everything's aligned properly, and restoring some initial function right there at the injury site. But here's the really key part. You're also actively teaching clients how to do their daily tasks safely. That means guiding them on how to move to protect that healing tissue. Or sometimes, just as importantly, how not to move.
Protective strategies.
It makes sense.
Then, when you shift to chronic conditions, say a client managing osteoarthritis, your role changes quite a bit. Sure, you might still be working on pain relief, maybe some realignment to reduce stress on the joint, but the big emphasis moves towards creating this really individualized education program. And it's not just about exercises. It's about helping the client make real, sustainable lifestyle changes, physically, psychologically, to manage their condition for the long haul. The goal is sustaining their optimal occupational functioning. So that balance, protecting the injury now versus those long-term goals, that's a constant juggling act, isn't it?
It really is. It's a dynamic calibration in your clinical reasoning, constantly weighing those factors. And that extends right into your evaluations.
Yeah, the sources really stress that evaluation in orthopedics isn't just a one-off event. It's an ongoing process tied to the client's recovery stage.
Which brings up a challenge, right? How do you gather all that info you need for treatment planning without, accidentally harming those healing structures?
That's a super critical challenge. You've got to be meticulous. Your choice of assessments is going to be guided by several really key things. You'll be looking at the specific post-surgical precautions from the surgeon. What stage of bone healing are they in? How was the fracture reduced and stabilized? Was it a simple cast, external fixation, maybe RIF? And of course, what's the status of the soft tissues? Is there still acute inflammation?
Okay, so lots of factors dictating what you can and can't assess right away. Exactly. And even if a client can't jump right back into their full life roles, assessing their participation in those roles, that's still your ultimate endpoint for planning treatment. It's your North Star for the whole rehab program.
Got it. So when we talk about assessing impairments, like ROM or strength, what are the rules there? What can you measure and when?
Great question. You have to be precise. Take range of motion or ROM. If the surgeon orders complete rest for that injured part, well, ROM measurements are just deferred. You don't do them. But if a controlled ROM program is prescribed, then you measure, but strictly within those specific boundaries. And here's a really important distinction. You measure the injured joint within its limits, but you also actively measure and encourage movement in the adjacent joints. Got to prevent that secondary stiffness.
Keep everything else moving. Good point. What about strength?
Similar principle. Detailed strength testing, especially with applied resistance, is deferred. You wait until you see clear signs of bony consolidation, good tissue healing, or until that acute inflammation has really calmed down. Applying force too early, that can disrupt everything. This is especially true for things like grip and pinch testing after forearm fractures. You typically wait about 2 to 4 weeks after the cast comes off, because those tests generate quite a bit of force.
Okay, deferring those strength tests makes sense. Is there anything else we should be looking at beyond those specific measurements?
Absolutely. Beyond the numbers, you need that holistic observation. You're constantly watching the client's total body response. Notice subtle postural shifts. How are they reacting to pain? What are their psychological responses? This broader, more qualitative view. It heavily influences your early intervention planning. It's not just about the goniometer reading, it's about the whole person.
Right, the whole person. That's key. Okay, let's shift focus a bit. Upper extremity fractures, these are so common. It's interesting, the sources mention this historical debate, movement versus rest. What's the modern thinking now?
Yeah, the debate went on for a long time. But modern orthopedics has pretty much landed on a clear goal. Achieve quick, compatible mobilization whenever possible. The aim is optimal recovery, yes, but also, critically, preserving overall function and preventing that awful stiffness that comes from just not moving.
So early movement, when safe, is generally preferred. How do surgeons achieve the stability needed for that?
Good question. They use different stabilization methods depending on the fracture. For stable, undisplaced, closed fractures, sometimes just protection alone is sufficient, maybe a sling. If it's unstable but still undisplaced, they'll use external fixation, things like slings, casts, or special fracture braces. And then there's open reduction internal fixation, or ORIF. That's surgery. It's for open fractures or unstable ones where the bone pieces can't be lined up properly without opening things up. The surgeon realigns the fragments and fixes them internally with hardware nails, pins, screws, plates, sometimes even prosthetic joints.
Okay, ORF for the more complex ones. And you mentioned healing stages. How does that fit in?
Understanding the phases of fracture healing is fundamental. You've got 3 main stages. First, the inflammation phase, just a few days. Then the reparative phase, usually 4 to 6 weeks, where the callus forms. And finally, the remodeling phase, which can actually go on for years as the bone gets stronger. The exact timelines vary, and we'll pop a quick reference on the website for you. But generally, upper extremity fractures heal faster than lower extremity ones. The key takeaway for you as a therapist: early, controlled movement, once allowed, is vital. It helps prevent stiffness, muscle wasting, weakness, all those bad side effects of being immobilized too long. It's a delicate balance.
Makes sense. Okay, let's zero in on probably the most challenging area.
Yeah.
Shoulder fractures. That whole complex is so intricate, isn't it?
Oh, absolutely. You've got the main glenohumeral joint, but also the scapulothoracic, sternoclavicular, acromioclavicular,
Yeah.
all work together. It's crucial for everything from placing your hand precisely for fine motor tasks to lifting heavy objects. It really is tough to rehab.
So for these complex shoulder cases, what are the main therapy goals?
It's multifaceted. You're aiming for pain relief, restoring movement and strength, making sure the callus forms correctly and the bone aligns well, and ultimately getting the client back to their maximal level of functioning. Radiographic imaging, which the surgeon follows, is key here. It really dictates how you progress exercises and when they can return to tasks.
You mentioned movement, and I know there's prom and stretching. What's the deal with those in early fracture healing?
That's a really critical distinction. Prom passive range of motion is just moving the limb through its available or allowed range using an external force, like your hand guiding their arm. Passive stretching, however, involves taking it to the end range and then applying overpressure to try and lengthen tissues. And that passive stretching, it's contraindicated in early fracture healing. It can disrupt the delicate repair process. So the emphasis, once movement is allowed, is on non-resistive functional activities, using the arm safely as soon as it's okay.
Got it. No aggressive stretching early on. Okay, what about managing these fractures without surgery? Conservative management.
Right, for stable and minimally displaced shoulder fractures where surgery isn't needed, you want to start motion pretty quickly once the acute pain settles down, because stiffness sets in fast. Usually starts with a sling for support. Then, controlled exercises can often begin as early as 1 to 2 weeks post-injury. These typically include Codman's pendulum exercises, where they bend over, let the arm hang, and do small gravity-assisted circles and swings, and also gentle prom, usually done lying down, supine, focusing on forward flexion, abduction in the scapular plane, and rotation. Though external rotation might be limited initially, you also start aromatic range of motion of all the uninvolved joints right away. Don't forget the elbow, wrist, hand. For ADLs, you'll teach one-handed techniques for safety. Around 4 weeks, maybe some gentle submaximal isometrics. By 6 weeks, they can often start arom, progressing carefully from gravity-lessened positions up to against gravity. And you have to watch really closely for compensation, like that classic shoulder hiking. Late self-care starts. The sling gets weaned off as arom improves. And then, usually around 8 to 12 weeks, isotonic strengthening can begin, with a return to sports or work activities after 12 weeks.
Okay, that's the non-op route. What about after surgery for those unstable fractures?
For postoperative management, the protocols often follow established guidelines, but they're always tailored. Specific fracture, the surgery done, client's age, activity level, it all matters. Some protocols push for very early mobilization, others might wait a bit, maybe 3 weeks. Interestingly, studies suggest the long-term functional outcomes are pretty similar either way.
So early versus slightly delayed mobilization might not make a huge difference long term.
Seems that way for function, yes, but the surgeon's protocol is always your guide. If approved, the exercise often starts with those Codman's pendulum exercises again. Bend over, let the arm hang, gentle swings. But here's a heads up for new therapists. If the arm is really swollen, edematous, Codman's might actually be contraindicated. Got to check that. In those first few weeks, 0 to 8 usually, prom for flexion and external rotation, often limited to maybe 40 degrees, is done supine. Isometrics are often included too. They can actually stimulate healing. Around 6 weeks, you start AROM, non-resistive therapeutic activities, light ADLs. Full strengthening usually waits until about 12 weeks.
And sometimes they do joint replacements for these fractures, right? Arthroplasty?
Yes, exactly. For severe cases, you might see a hemiarthroplasty, which is just replacing the humeral head, or a total shoulder arthroplasty, TSA, often for severe arthritis, combined with a fracture. And then there's the reverse total shoulder replacement. That's typically used when the rotator cuff is really damaged or there's severe arthritis. The big limitation there is often impaired shoulder rotation.
Okay. So if you have a client post-TSA, total shoulder arthroplasty, what does that rehab look like, especially if it's an early mobilization protocol?
Therapy starts fast for early mobilization TSAs, often day 1 or 2 post-op. The absolute key. Exercises must not cause pain. Achieving early shoulder elevation and external rotation, specifically in the scapular plane, is crucial for a good outcome. Passive elevation is done supine, using the other hand to help. An exercise wand or stick helps with passive external rotation, which might be initially limited to, say, 30 degrees. Codmans usually start around week 1. They need to do these exercises multiple times a day. Now, because the subscapularis tendon might be cut during surgery, sometimes external rotation is introduced slowly over the first 4 weeks, but some surgeons allow it right away. Got to check the protocol. During this early phase, non-resistive ADLs, brushing teeth, feeding yourself are encouraged, but always keeping the shoulder adducted, close to the body. Submaximal isometrics come in around 3 weeks. AROM starts at 6 weeks, moving from gravity lessened like lying down to against gravity, sitting or standing, and always watching for that shoulder hike. Between 8 and 12 weeks, you introduce resistance TheraBand, light free weights. By 12 weeks, they can start thinking about sports and work activities. But, and this is a big one, no weight bearing on that injured arm for at least 6 months. Strict precaution. The ultimate goals, usually aiming for around 135 degrees of elevation in scaption, that movement slightly forward in the scapular plane, and about 50 degrees of internal and external rotation. That's considered functional AROM.
Wow, 6 months, no weight bearing. That's significant. Okay, moving down the arm. Humeral shaft fractures. What's typical there?
For humeral shaft fractures, often you'll see a functional fracture brace, like the Sarmiento brace. It's usually lightweight plastic, and it cleverly allows motion above and below the fracture site. This helps minimize those bad effects of immobilization. Your role as the therapist is to monitor alignment, make sure movement is controlled, adjust the brace as needed. Management includes Codmans and PROM daily to prevent stiffness. A big risk with these fractures, due to anatomy, is radial nerve damage. You'd see an inability to extend the elbow, wrist, digits. Gotta watch for that. Delayed union or non-union can also happen. Rehab moves through phases. Phase 2 involves AROM to AROM, light resistance, timed by the surgeon. Phase 3 focuses on more intense stretching, strengthening, allowing combined movements as healing allows.
Okay, shoulder and shaft covered. Now the elbow seems less complex maybe, but why is elbow motion so important? And what are the red flags students need to watch for with elbow fractures?
Don't underestimate the elbow. It's absolutely vital. It lets us position our hand perfectly, whether close up for fine motor stuff or further out for strength tasks. It gives us flexion extension and also forearm pronation supination. Common distal humerus fractures impacting the elbow are intercondylar and supracondylar types. These carry risks: Malunion, nerve injury, and critically, Volkmann's ischemia. That's a compartment syndrome in the forearm.
Volkmann's ischemia. That sounds serious. What are the signs?
I is serious. It's an orthopedic emergency. You must report signs immediately. It's caused by pressure building up in a muscle compartment, cutting off blood flow. The classic signs are the 5 Ps. Severe, pain with passive stretching, often the earliest and most telling sign. Pallor, pale bluish skin. paresthesia, decreased sensation, paralysis, and pulselessness, absent radial pulse in the forearm. Surgery, often a decompressive fasciotomy, is needed urgently. A bad complication is Volkmann's ischemic contracture, which causes major functional problems. Your OT focus, once the crisis is over, shifts quickly to restoring ROM, scar management, regaining function.
Okay, 5 Ps, immediate report. Got it. What about less severe elbow fractures, like a non-displaced supracondylar?
For those non-displaced supracondylar fractures, treatment is usually closed reduction and immobilization in a removable cast or a thermoplastic splint. After maybe 1 or 2 weeks, the splint comes off daily for gentle AROM, often done within a protective hinge splint. Splint's usually done by 6 weeks, and they start using the arm for light ADLs.
And the more complex elbow fractures, displaced ones.
Those, like displaced supracondylar or intercondylar fractures, almost always need ORF open reduction internal fixation. Active motion usually starts very early, like within 2 or 3 days post-op. They're often splinted at 90 degrees of flexion, not extension, because flexion is more functionally important for daily tasks. You, the therapist, will remove the splint for gentle AROM. Elbow flexion extension is best done supine or seated with the upper arm supported. You must follow any ROM restrictions strictly, especially if ligaments were involved. Forearm ROM, pronation supination, is done with the elbow bent at 90 degrees. Gentle prom and light isotonic exercises usually start around 6 to 8 weeks, along with light self-care. At 8 weeks, the push for full ROM and strength really increases. Interestingly, for elderly clients, sometimes elbow fractures are just treated with a sling and early active movement. The goal is often a functional arc of motion rather than full ROM to prevent stiffness.
And briefly, radial head fractures. Anything specific there?
Radial head fractures are also just managed with a sling initially. But early active pronation and supination are really encouraged. A key focus should be regaining active supination, turning the palm up, as that's usually harder and more painful than pronation. Do these exercises with the shoulder adducted, elbow at 90, several times a day, pain-free. Sometimes continuous passive motion CPM machines, dynamic splints, or static progressive splints are used to help get that forearm rotation back if needed.
Okay, great overview of fractures.
Yeah.
Let's pivot now to something else incredibly common, rotator cuff issues. Our sources really hammer home how vital that rotator cuff group supraspinatus, infraspinatus, teres minor, subscapularis is for shoulder function. They act as a force couple, right? Stabilizing the humerus.
Exactly. They work together in this beautifully coordinated way to control the humeral head in the socket. But their location, tucked into that tight subacromial space, makes them really vulnerable to compression or impingement. The supraspinatus tendon is the most common culprit, partly due to anatomy like a hook acromion shape, and also because it has a critical zone with relatively poor blood supply.
And when that system is compromised, what does that mean for someone's daily life, their ADLs?
It can be devastating for independence. Think about basic self-care. Clients often struggle with toileting, washing their hair, hooking a bra. Anything that requires reaching overhead or behind the back becomes painful or impossible.
Let's break down shoulder impingement syndrome specifically. What's happening there?
It's essentially a mechanical compression of the structures in that subacromial space. The bursa, supraspinatus tendon, joint capsule, maybe the long head of the biceps tendon. Causes can be structural, like that hooked acromion we mentioned, or functional, like repetitive or sustained arm elevation above 90 degrees, which physically pinches those tissues. If it's not addressed, it can progress, unfortunately, often leading to rotator cuff tears. Neer's classification helps understand that progression. Stage 1 is basically inflammation, edema, maybe some minor bleeding, often reversible with OT focusing on activity modification. Stage 2, the tissues start to get thick and fibrotic. Conservative treatment is still possible, but it takes longer. Stage 3 involves bone spurs and actual tears, partial or full thickness. And those tears get classified by size: small, medium, large, massive.
Okay, so impingement can lead to tears. What about tendonitis and bursitis? Are they the same thing?
Not quite, though they often coexist. Rotator cuff tendonitis and bicipital tendonitis inflammation of those tendons usually present with pain during arm movement, especially above 90 degrees. Clients might be independent in ADLs, but it hurts to do them. Causes are similar to impingement: repetitive overhead use, acromion shape, muscle weakness, tight capsule. Conservative treatment involves pain modalities, modifying activities, strengthening, and occupation-based activities. Bursitis inflammation of the subacromial bursa can sometimes be differentiated if the pain occurs during passive shoulder elevation, but they're pain-free with active movement or resisted testing of the cuff muscles. Honestly, significant bursitis is rarely the main issue on its own. It usually tags along with impingement.
And then the actual rotator cuff tears, how do those happen, and what does it look like clinically?
Tears can happen from trauma, like a fall, or they can be the end result of chronic impingement. Degenerative changes with aging are also a major factor. Clinically, people have difficulty with activities above shoulder level. You'll often see that compensatory shoulder hiking, where they use their upper trap muscle to try and lift the arm. Rotational movements, like reaching into a back pocket, are often limited too. It really impacts occupational functioning significantly. Diagnosis is usually confirmed with an MRI or MRA. For some partial tears, conservative treatment activity mods strengthening the scapula and cuff can work. But many tears, especially full-thickness ones, require surgery. Arthroscopic, mini-open, or open repairs. Post-op therapy then focuses intensely on regaining full ROM, strengthening, and getting back to ADLs.
That's a clear pathway from impingement to tear. So for that non-surgical client who walks into the clinic, what's crucial in your evaluation? What really stands out?
Okay, for the non-surgical client, your evaluation has to start with a really solid occupational profile and history. You need the mechanism, sudden injury or gradual onset. If gradual, what specific activities or postures might be involved? Pain details, 0-10 scale. Where is it? Does it radiate? Does it wake them up at night? What makes it worse? Then observation. Look at their posture. Are the scapulae symmetrical at rest? What happens when they try to raise their arm? Assess functional movements, reaching the low back, opposite armpit, top of the head, and critically, you need to rule out the neck. Do active cervical ROM, check sensation in the C4T1 dermatomes. Don't miss a cervical radiculopathy masquerading as shoulder pain. Palpation helps locate tenderness or swelling over the cuff tendons.
And the special tests, those seem really key for diagnosis.
Absolutely critical. Knowing how to perform and interpret these is essential fieldwork knowledge. Let's run through the main ones. Near impingement sign. You passively force their arm into forward flexion with internal rotation. Pain. Positive sign for impingement of supraspinatus or long head of biceps, Hawkins test. Shoulder and elbow flex to 90, then you passively force internal rotation. Pain again suggests impingement of those same structures. Job's test or MTCAN test. Arm elevated to 45 degrees, internally rotated, thumb down, then resist subduction. Weakness or pain points to a supraspinatus tear. Quick note, if pain is only at 90 degrees, it might be bursitis. Drop arm test. Have them hold the arm at 90 degrees subduction, then slowly lower it if it just drops uncontrollably. Positive for a supraspinatus tear. And the biceps beats test. Shoulder at 90 flexion, forearm supinated, elbows straight. Resist their attempt to flex further. Pain right over the bicipital groove is a positive sign.
Okay, Naren, Hawkins, Job, drop arm speeds. Got it. What else?
After those, you absolutely need to assess ADLs. Watch them use the arm, low range, mid range, high range, mood compensation, pain behaviors. And finally, use standardized functional assessments. Things like the DSH, disabilities of arm, shoulder, and hand, or the ACEs, American Shoulder and Elbow Surgeons Self-Report. These give you objective data on their perceived function.
Very thorough. So once you have that evaluation done for the non-surgical client, how does treatment typically proceed? What are the first steps?
Conservative treatment always starts with education, specifically activity modification. They have to avoid activities above shoulder level until the pain settles down. No pushing through the pain. Sleeping posture is huge too. Teach them to avoid sleeping with the arm overhead or tucked under them in adduction internal rotation. That position can really compromise blood flow to the supraspinatus. Use pillows for support.
Okay, education first, then exercises.
Yes, exercise progression starts gently. Pain-free ROM first, usually PROM initially, then moving to AROM as pain allows. Strengthening follows, starting with isometrics, then progressing to isotonic exercises for both the rotator cuff muscles and the important scapular stabilizers. And crucially, integrate these movements into functional activities. Dressing, reaching for things. Make it meaningful. Find out what occupations matter to them. If they golf, maybe incorporate gentle swings later on. Bring in their actual equipment if it's safe. The long-term aim. Unrestricted, pain-free occupational functioning.
Makes sense. Now, for the post-surgical client, evaluation and treatment are obviously going to be different, driven by the surgeon's protocol, right?
Absolutely. Everything is guided by the surgeon-specific protocol. You might get the referral very early, like 24 hours post-op, or it might be delayed, maybe up to 6 weeks. The timing depends on so many things. Tear size, location, tissue quality, the surgical approach used, and the surgeon's own philosophy and preferred protocol.
And the treatment itself, what does that typically involve after rotator cuff surgery?
Well, as we touched on with fractures, both early and delayed mobilization protocols seem to yield similar results long-term for healing and function. So the timing of when you start depends on all those factors: tear size, repair type, tissue quality, protocol. They'll usually be in an abduction pillow brace or a sling. Emphasize that it needs to be worn at all times except during prescribed exercises. And always clarify bathing instructions with the surgeon.
Okay, brace on most of the time. What exercises do you start with, say, for small or medium tiers?
For small to medium tiers, the initial phase is usually prom or arom. Focus on pain-free Codman's pendulums, passive shoulder elevation, usually supine, and passive internal-external rotation done in slight abduction within the scapular plane. Ice packs are your friend before, during, after exercises for pain and swelling. Teach them how to use their uninvolved arm to assist the operated arm for these exercises. For rotation, they often lie supine, shoulder may be 30 degrees abducted, elbow at 90, using a cane or stick with the good arm to guide the operated arm. ROM limits are strictly set by the surgeon, don't guess. You also start arom with the elbow, forearm, wrist, and hand right away to prevent stiffness there. One key point, overhead pulleys should only be used if the surgeon specifically asks for them. Repetitive elevation can sometimes irritate the repair site.
Okay, passive movements, respecting limits. What about daily activities?
During this early phase, it's all about one-handed techniques for ADLs. The involved shoulder is generally not used for anything unless the surgeon specifically indicates it's okay. Around 6 weeks post-op, or maybe later if it was a delayed protocol, you start progressing to arom. Start gravity lesson, then move to against gravity. Shoulder extension and internal rotation like reaching the small of the back are added when the surgeon approves. The goal now is achieving functional ROM. Start incorporating light, non-resistive ADLs, but watch like a hawk for compensation, scapular hiking, trunk bending.
And strengthening, when does that usually come in?
Strengthening typically starts around 10 to 12 weeks post-op. Begin with isometrics for the rotator cuff and scapular stabilizers. Then progress to isotonic exercises, TheraBand, light free weights, big rule. All strengthening must be done below 90 degrees of shoulder elevation and be pain-free. Start supine with weights to minimize gravity, then progress to against gravity, but still stay below that 90-degree mark initially. Later, you can introduce light ADLs above shoulder level, maybe cooking, folding laundry if there's no hiking compensation. By 12 weeks, they might start light resistive, occupation-based tasks, but another strict precaution, no lifting over 5 pounds. Long-term goal, as always, normal, pain-free occupational functioning.
That's a detailed timeline. What about those large or massive tears? Is it different?
Yes, significantly. For large and massive tears, they're often immobilized longer, typically in an abduction brace. ROM often starts only with pendulum exercises. Prom restrictions can vary hugely, sometimes starting in the first week, sometimes delayed up to 6 weeks. SHROM typically doesn't begin until 8 to 12 weeks post-op. The preparatory interventions and activities are similar in type, but the whole timeline is pushed back, often considerably. For these complex cases, ongoing close communication with the surgeon is absolutely essential. You need to be on the same page every step of the way.
That level of detail is so helpful for students. Let's make it real with that case study. Lucy, the 68-year-old, post-arthroscopic supraspinatus repair, discharged home alone. Challenges with ROM, pain, dressing, hair care, cooking. How did OT help her?
Lucy's case is a fantastic example. She got an outpatient OT referral for ADL, IADL independence, gentle prom to the right shoulder, and arom to uninvolved joints.
Okay, what did the assessment find?
Initial assessment showed she lived alone, small kitchen, loved gardening and cooking. Her left arm and right hand joints were fine, full arom, but her right shoulder prom was really limited. Only 0.85 degrees elevation, internal rotation just to her stomach, external rotation only 0.10 degrees. Pain was high, 7:10, worse at night. Functionally, she needed help getting dressed, couldn't get her right arm into his sleeve easily. Hair washing one-handed was a nightmare. Cooking was basically impossible due to precautions, couldn't open things, cut, lift pots, couldn't drive, worried about groceries.
Yeah, that sounds tough, living alone. What were the OT problems identified?
Pretty clear. Decreased ROM, decreased AD-LID-LAL independence, and shoulder pain messing with her sleep.
And the goals, were they occupation-focused?
Absolutely. Very functional goals. 1. Increase prom shoulder elevation to 130 degrees in 2 weeks, specifically so she could do her hair. 2. Decrease pain to 510 in 1 week, focusing on proper positioning for comfort.
Yeah.
3. Modified independent cutting food with a rocker knife in 1 week, enabling cooking. 4. Modified independent upper body dressing in 1 week. 5. Modified independent simple meal prep, one-handed, in 1 week, getting her back to that meaningful activity.
Great goals. How did the intervention roll out?
The intervention started right away. Hot pack for prep, then passive pendulums and prom exercises, supine, for elevation and rotation. She got a home program for pendulums 3 times daily, And crucially, teaching her proper sleeping position with pillow support, slight elevation, slight external rotation made a huge difference in her night pain almost immediately.
Nice, quick win with the positioning. What about the ADLs?
For ADLs, the therapist taught specific one-handed techniques, like for putting on a button-down shirt. Release the arm from the sling, let it pendulum, use the left hand to gently guide the sleeve on, reach behind the neck for the collar, button from the bottom up. Smart sequencing. She learned one-handed cutting, how to open containers for cooking. She achieved modified independence pretty quickly with those strategies.
That's fantastic progress. How did things look later on?
At 6 weeks, her prom was way better. 150-degree elevation, still IR to stomach, but ER out to 50 degrees. Pain down to 410. Modified independent with her one-handed ADLs. At 8 weeks, the physician okayed AirROM, then strengthening. OT started AirROM supine first, gravity lessened. Introduced cane exercises, wall walking, functional precursors to reaching into cabinets for cooking. Strengthening progressed from isometrics to isotonics. And the best part, before discharge, the therapist had Lucy cook a full meal, something meaningful to her, and she did it independently, using her arm without compensation. It perfectly shows that progression from specific exercises right back into real-life, meaningful occupation. That's OT.
Love that. Okay, shifting from acute injuries and post-op rehab, let's tackle chronic orthopedic conditions, starting with rheumatoid arthritis, RA. Our sources describe it as autoimmune, chronic, systemic, inflammatory, hitting women more often, usually starting between 30 and 60. What's actually going on inside the body with RA? Why is it so destructive?
Yeah, the etiology and pathophysiology of RA are complex. It's not just one thing. It's likely an interplay of genetics, hormones, environmental factors, maybe lifestyle. And joint damage can start really early, within months of symptoms. The changes it causes are profound and destructive. Synovitis. The synovial membrane lining the joint gets inflamed and thickens, producing way too much fluid. That causes the swelling, warmth, and pain. Pannus. This is the really nasty part. It's like this aggressive inflammatory tissue that grows over and starts invading and eroding the bone and cartilage. Literally eats away at the joint. Cachexia. People can lose muscle mass due to the systemic inflammation affecting muscles and metabolism. Joint instability. All that chronic swelling stretches and weakens the ligaments and joint capsules, making the joints unstable. Joint deformity follows instability. Weakened structures allow abnormal movement patterns and eventual deformity. Fatigue. This is a huge one for people with RA, often debilitating, likely due to those inflammatory proteins circulating systemically.
Wow, that pannus sounds particularly damaging. Does RA always progress the same way?
No, the course and prognosis vary a lot. About 20% have a monocyclic course, one episode, often stopped by early aggressive treatment with DMARDs, disease-modifying anti-rheumatic drugs. About 75% have a polycyclic course, flares and remissions, fluctuating activity over many years. And maybe 5% have a progressive course, rapid, relentless increase in severity.
And the symptoms people experience.
The classic signs and symptoms include that symmetrical pattern, multiple joints on both sides of the body affected, polyarticular, lots of pain, swelling, edema, malaise, fatigue. A real hallmark is severe early morning stiffness, sometimes lasting for hours. It's not just joints either. RA can affect eyes, skin, lungs, heart. It's systemic. Onset is usually gradual, often starting in the hands and feet, but sometimes it hits fast, maybe 20% of cases. In the upper limb, the most commonly affected joints are wrists, MCPs, knuckles, elbows, PIPs, middle finger joints, and shoulders. And the RA hand itself, it's often severely affected, right? What kinds of changes do we see? Oh, yes. Even in early RA, sources show significant losses. Less wrist motion, less MCP flexion, and a huge drop in grip and pinch strength, maybe only 60% of normal power. About a third develop visible hand deformities, though hopefully early aggressive DMARD therapy is reducing how common those severe deformities become. Deformities develop from that persistent synovitis messing up joint structures, combined with abnormal forces during hand use. Like using a strong power grip repeatedly naturally pushes the MCP joints towards ulnar deviation in a joint already weakened by RA.
Can you walk us through some of those specific deformities? Understanding them seems key for assessment and splinting.
Definitely. Let's trace a few common ones. At the wrist joint, early inflammation often starts on the ulnar side, disrupting the triangular fibrocartilage complex, TFCC. This lets the proximal carpal bones rotate ulnarward. The distal row compensates radially. Ligaments get lax, the extensor carpi ulnaris tendon can slip out of place, all increasing risk of the wrist subluxing volarly downwards. That radial deviation at the wrist then pulls the MCPs ulnar. They often go together.
Okay, wrist instability contributing to finger deviation. What about the MCP joints themselves?
At the MCPs, knuckles, synovitis weakens the collateral ligaments, the volar plates underneath, the dorsal hoods on top, leading to instability. The Finger extensor tendons can actually slip down and sideways, volarly and ulnarly, so instead of extending the finger, they act like weak flexors. Plus, normal anatomy contributes. Flexor tendons approach from the ulnar side, the shape of the metacarpal head allows ulnar slipping, and the ulnar intrinsic muscles are stronger than the radial ones, all push towards that typical under deviation.
Wow, the tendons actually start working against extension. Okay, what about the IP joints, the finger joints?
At the interphalangeal IP joints, synovitis can disrupt the extensor mechanism. If the central slip is damaged, you get a boutonniere deformity PIP joint stuck in flexion, DIP joint hyperextended. Similar disruptions cause the Z deformity of the R thumb. IP joint hyperextends, MCP joint flexes. Also, MCP inflammation can cause the intrinsic muscles, interossellae, to spasm protectively. This pulls the hand into an intrinsic plus position. MCPs flex when trying to extend fingers, which itself contributes to boutonniere and swan neck deformities.
And the swan neck deformity, what's happening there?
Swan neck is the opposite of boutonniere. The PIP joint hyperextends and the DIP joint flexes. It happens when the lateral bands of the extensor mechanism get stretched and slip below the axis of the PIP joint, pulling it into hyperextension. Then the terminal extensor tendon flexes the DIP. Splinting often uses a three-point pressure system to gently realign it.
These deformities sound complex. How is RA managed medically?
The main goal of medical management is rapid reduction of inflammation to prevent or limit that joint damage. Early use of DORs like methotrexate is key for better long-term outcomes. Often, combination therapy is used for moderate to severe disease. Biologic drugs are used if DRs aren't enough or if the prognosis looks poor. These meds have really made a difference, significantly reducing that aggressive synovial tissue growth and lessening the severe deformities we used to see more often. Surgery is still an option too. Synovectomy, removing an inflamed synovium, tenosynovectomy, tendon repairs, transfers, joint replacements, arthroplasty, or joint fusions, arthrodesis.
Okay, that's a deep dive into RA. Now let's switch to osteoarthritis, OA. Our sources call it the most common form of arthritis, a huge cause of pain and disability. How is OA different from RA?
While they both cause joint pain, OA is really defined as a clinical syndrome of joint pain linked with degenerative changes, not that systemic inflammation of RA. It affects millions, over 30 million adults in the U.S. Your lifetime risk of getting symptomatic OA is pretty high, 25% for the hip, almost 46% for the knee, 40% for the hand, hits women over 50 more, men under 45 more.
So it's wear and tear, or more complex than that.
It used to be thought of as just wear and tear, but it's much more complex. The etiology and pathophysiology involve damage to the joint cartilage, yes, but from multiple risk factors. Genetics play a role. Constitutional factors like age and weight matter, and biomechanical factors are huge: previous injury, overuse, muscle weakness, joint misalignment. It's actually a metabolically active process involving all the joint tissues. You see structural changes like fibrillation, the cartilage softens and gets little cracks. Eventually you lose cartilage thickness. The bone underneath remodels, forming osteophytes or bone spurs. You can also get some focal synovitis from irritation. Think of OA initially as a repair process. The body tries to fix the damage. It only becomes symptomatic if the damage keeps happening or the repair process isn't effective enough or you just run out of cartilage, chondropenia.
Interesting. So the body's trying to repair, but it can get overwhelmed. How does OA typically progress?
The course and prognosis vary. It might hit just one joint or several. Onset is usually gradual. Knee OA often progresses and may eventually need replacement. IP joint OA in the fingers can actually become less painful over time, but those bony nodes usually stick around. Thumb base, CMC joint OA often remains painful and disabling. Hip OA generally has the poorest outcome functionally, often needing replacement.
And the symptoms, how does OA feel compared to RA?
Signs and symptoms include joint pain, but initially it's often worse with activity and gets better with rest. Later, pain can become persistent, even waking people up at night. The pain comes from stretching nerve endings in the capsule, increased pressure in the bone under the cartilage, muscle spasms. Joint stiffness is common, but it's different from RA. It's often called the gel phenomenon, stiffness after sleep or inactivity, but it usually lasts only 5 to 30 minutes and improves with movement. RA stiffness lasts much longer. People get post-activity flare-ups with swelling and pain. They start guarding the joint, which leads to weakness and less ROM. In advanced cases, you might hear or feel crepitus, that crunching or grating sound with movement. And a unique thing, hip OA often presents as groin pain, not hip pain.
Good distinctions. What about hand OA? Where does it typically show up and what deformities do we see?
In the hand, OA most commonly hits the DIP joints, closest to the fingertip, and the CMC joint, base of the thumb. That repair process leads to osteophyte formation, bony enlargements, and some synovitis, which causes ligament laxity and deformities. You see, Bouchard notes those hard, bony bumps at the PIP joints, middle knuckle, and Heberden notes similar bumps, but at the DIP joints and knuckle. You can get a mallet finger deformity at the DIP if the extensor tendon attachment gets messed up by the bone spurs. The classic thumb deformity in OA involves squaring at the CMC joint base, often with a Z deformity of the OA thumb, CMC joint adducted, MCP joint hyperextended, IP joint flexed. You'll also see muscle wasting in the thenar eminence, base of thumb, and generally reduced finger, thumb, and wrist movement.
How is OA managed medically? Is it similar to RA?
Medical management goals are similar: decrease pain stiffness, improve mobility, but the approach is different because it's not systemic inflammation. Pharmacotherapy often starts with acetaminophen, topical NSAIDs, then maybe oral NSAIDs or capsaicin cream. Intra-articular steroid injections can help flare-ups. Newer drugs are being developed too. Surgery is an option if conservative treatment fails. Joint replacements, hip, knee, are common. For the thumb CMC joint, arthroplasty is often done. Arthrodesis, joint fusion, is reserved for the most painful joints where stability and pain relief are more important than movement.
So we've got RA with its systemic inflammation and specific deformities, and OA with its degenerative changes in bony nodes. After all that detail, what does this mean for your patients in their everyday lives? What's the real-world functional impact?
The impact is huge. It translates to a major loss of productivity. Many people with ORA are diagnosed during their peak working years. Sources say about 60% with early RA have trouble with hand function and ADLs. A shocking 20% to 70% stop working within 7-10 years of diagnosis. And once they stop, they rarely go back. This really highlights the need for OT, especially for hand function, ADLs, and vocational rehab. For OA, about 80% have some movement limitation, and a quarter can't perform major ADLs. 1 in 5 give up work or retire early because of it. And despite knowing that activity helps decreases pain, improves function, even reduces healthcare costs, a lot of adults with arthritis just aren't active. These numbers really paint a picture of how profoundly these conditions affect people's ability to participate in life, their work, their quality of life. It's where we, as OTs, can really make a difference.
Absolutely. That functional impact underscores why a comprehensive OT evaluation is so critical. The sources emphasize it's not just about identifying physical limits, but understanding how those limits hit participation in life roles.
Exactly. The initial interview is where you start building that picture. Always begin with a thorough chart review. Medical history, other conditions, meds especially for RA, knowing their DMARD biologic timing can be important. Get a social history, living situation, caregiving roles, type of home. You need a summary of their prior function versus present function across all occupation areas: ADL, IDL, rest, sleep, work, education, leisure, social life. The Canadian Occupational Performance Measure, COHI-OPM, is fantastic for this. It's semi-structured, takes 20-40 minutes, and really focuses on their perceived problems in activity and participation. You help them identify maybe 5 key problems, then they rate importance, performance, satisfaction.
COPM helps pinpoint their priorities. And as they talk about problems, you mentioned digging into the why.
Yes. Exploring the why is crucial. Is the difficulty due to pain, fatigue, stiffness, physical limits like ROM or strength? Or are there environmental barrier steps, lack of equipment? Or maybe psychological factors, poor concentration, low mood, lack of confidence, fear of pain, or fatigue? You also need to understand their daily routine, typical weekday versus weekend. How much activity, rest, leisure? Do they pace themselves or push through? What's their understanding of their condition? How well do they self-manage? This deep dive guides everything else.
That's getting the whole story. Okay, when assessing specific body functions and activity limits, how do you decide? Observe them doing it, or ask them about it using questionnaires. And what are some key assessment tools we might see used in fieldwork?
Good question on observation versus self-report. ADL observation is best if someone can't reliably self-report, maybe cognitive issues, post-surgery confusion, poor self-awareness. But often, interviews and self-report questionnaires are better, especially if low mood is a factor, common in RAOA. They're also quicker and can flag areas needing deeper assessment.
Okay, so tool selection depends on the client and the situation. What are some common names we should recognize?
You'll definitely come across tools like the Health Assessment Questionnaire, HAQ. It's a quick screen for various functional categories. One limitation, though: scores worsen if assistive devices are used, so it's not ideal as an OT outcome measure showing improvement with devices. Patient-rated tools like the Patient-Rated Wrist and Hand Evaluation, PRWHE, or the Michigan Hand Outcomes Questionnaire are really valuable for getting the client's perspective on pain and function. Great for goal setting. For a really comprehensive look at how arthritis impacts daily life, including ergonomics and assistive tech use, there's the Evaluation of Daily Activity Questionnaire, EDAQ. And to capture the broader impact, including psychosocial aspects, the Arthritis Impact Measurement Scale 2, AMIS 2, is very thorough. There are others too, like the SVLA for life activities in RA or the MAP hand for screening hand function deficits. We'll list these in the show notes, but the key is knowing why you're using a specific tool. What question are you trying to answer?
Got it. Tools for different purposes. What about tracking activity levels?
Activity diaries are incredibly useful for that. Have the client track a typical weekday and weekend, maybe in half-hour blocks. Note main activity, rate pain fatigue, 0-10. Note rest breaks. It really helps visualize their occupational balance or imbalance and patterns of activity. And for a quick general musculoskeletal screen, the gait, arms, legs, spine, GALS exam is quick, reliable, and valid.
Okay, diaries and GALS for broader views. What about the specific hands-on physical assessment of the hand and upper limb?
Right, the objective measures. For RA, you might do a tender and swollen joint count, especially for splinting decisions or tracking progress. Volumetry measures overall hand swelling, edema. Circumferential measurements are better for tracking swelling in a specific joint. Compare sides or adjacent joints. Always document hand appearance, carefully note swelling, pain, deformity on a hand chart. Digital photos can be really helpful over time. Range of motion, ROM, is measured with a goniometer using standard, precise techniques. Grip strength usually uses a Jamar dynamometer. Pinch strength uses a teach gauge, measures lateral, three-jaw chuck, and tip pinch. Both have normative data available for comparison. Manual muscle testing, MMT, graded 1 or 5, is especially useful for tracking nerve lesion recovery. Sensation testing, often with semis monofilaments, checks for nerve involvement and, crucially, protective sensation. Also observe the hand for subtle signs like dryness, shininess, less wrinkling, muscle wasting.
Lots of specific measures there. Any functional tests for the hand?
Yes, several good ones. Moberg pickup test. Good for median nerve function. How fast can they pick up small objects, with and without looking? Box and block test. Measures gross manual dexterity, how many blocks moved in 1 minute. Purdue pegboard test. Assesses finger and fine motor dexterity, putting pegs in holes quickly and accurately. 9-hole peg test, NHPT. Another simple, quick test for unilateral fine dexterity. These give you a picture of function beyond just isolated strength or ROM.
What if the person is working? How do you assess that aspect?
Work assessments are vital if it's relevant to the client. Start with interviews, maybe use screening tools or self-assessments like the Work Environment Survey Rheumatic Conditions. The Ergonomic Assessment Tool for Arthritis, EATA, helps document tasks, equipment, postures, demands. It can guide a worksite visit or inform an interview. And for a really comprehensive assessment of workability, you might use a Functional Capacity Evaluation, FCE. That's an umbrella term for systems like WorkHab or WorkWell that assess capacity for specific work demands.
Okay, now here's where OT really shines. The psychosocial factors. This goes way beyond just the physical, doesn't it?
Well, absolutely. As OTs, we have to look at the mental functions underlying coping and adaptation. If things like depression, anxiety, fear of movement, body image issues are impacting occupational function, they need assessment and intervention. How someone adapts is hugely influenced by their body image, their functional needs, their context, family, culture, social environment, the personal meaning of the hand, self-esteem, support systems, coping styles. They all play a massive role in outcomes. We need to empower clients, ensure health literacy, listen actively, use clear language, avoid jargon, use diagrams, build rapport. Ultimately, motivation is probably the single most important factor for recovery. Setting realistic expectations, using participatory decision-making, education, that's key. Addressing psychosocial symptoms early leads to better outcomes.
Such a crucial part of our role. So you've done this incredibly thorough assessment, gathered all this data. What does it mean for setting goals day to day in the clinic? How do we keep them occupation focused?
Goals must reflect the client's desired occupational performance. This is core OT philosophy. Honestly, the degrees of ROM gained matter far less than whether the client can actually open a jar, dress themselves, or get back to their job. To be truly aligned with OT, all your documented goals need occupation as the primary focus. Sure, you might track underlying factors like strength or ROM for your own clinical reasoning, but the goals in the chart, they should be about doing things. You can use internal behavioral objectives not in the official record to map out how you'll address those underlying factors, like improving supination or strength, to achieve the bigger occupational goal, like washing their face.
Okay, occupation as the focus for formal goals. How do we bring occupation into the treatment itself?
That's occupation as means. You integrate the client's own goals and typical daily activities right into the therapy session. Think about it. Occupation naturally demands adaptive responses that you just don't get from rote exercise alone. Activities promote better coordination, better movement quality. So yeah, squeezing therapy putty works grip strength. But putting away groceries starting light, getting heavier, that's an occupation-based activity that builds strength and endurance in a functional context. Client loves baking. Rolling dough works grip and wrist stability. This is how we weave OT's heritage into rehab, making it truly meaningful.
Okay, that sets the stage perfectly. We've covered foundations, assessment, goal setting. Now let's dive into the core interventions you'll actually be using in orthopedic hand therapy. How do you decide what to do and when?
It always comes back to respecting the stages of inflammation. Acute stage, gentle passive active ROM to the point of pain. Critically, no stretching. Subacute stage. Now you can introduce active passive ROM, gentle passive stretch, maybe some isotonic graded isometrics, but always with minimal stress. Chronic active inactive stages. Treatment can include stretching at end range and resistive exercises, isotonous isometric, as long as they don't stress the joints excessively. Across all stages, key principles. Respect pain. Avoid fatigue. Manage stress. Prevent deformities. Don't stress inflamed tissues. Use thermal modalities cautiously. Be careful with resistive exercise. Know about any sensory issues. Promote weight bearing, ROM with intolerance, and general aerobic fitness.
Okay, respecting the stages. What are some of the bread and butter interventions? Let's start with edema. Swelling seems like a constant issue.
It often is. For edema control, the mainstays are elevation, active exercise movement, and compression. First, though, you need to figure out the type of edema. Is it typical peripheral edema from inflammation, leaky capillaries, or is it lymphedema more chronic, pitting from impaired lymphatics? Lymphedema needs a specialized approach, often from a certified lymphedema therapist. For typical post-injury edema, effective techniques include encouraging use of the hand within pain limits, elevating it above the heart when resting, avoiding letting it hang down, gentle hand pumping, making a fist with elevation, contrast baths, alternating warm-cool water, and compression gloves. Kinesiotaping can also help reduce edema and pain without restricting use too much, but always be careful with fragile skin.
Okay, elevation, movement, compression, maybe K-tape. What about scar tissue? That seems like another major barrier to function.
Huge barrier. Scar management is critical. Scar tissue can restrict movement, cause pain. Traditional methods include compression, using things like isotoner gloves, 2B grip elastic stockinette, Coban wrap, and mechanical vibration to help soften and mature the scar. Silicone gel sheets applied over the scar or topical creams can improve appearance. You can also insert padding or elastomer materials into gloves or orthotics to provide more focused, even compression over the scar. And interestingly, simple micropore tape applied along incision lines is proving quite effective and affordable for scar management.
Micropore tape. Interesting. Okay, let's unpack something specific. Differential digital tendon gliding exercises. Why are these drilled into us? Why so important?
They're absolutely fundamental because they maximize not just total tendon glide, but the differential glide, meaning the FDS and FDP tendons gliding separately from each other and from surrounding tissues. This is crucial for preventing or breaking down scar adhesions, which are notorious for limiting finger motion after tendon injuries, crush injuries, even some fractures. Adhesions are a primary reason for long-term dysfunction. So these exercises are a core part of most home programs. You can integrate the movements into functional tasks too, things that involve hook grips or full fist grips, like kneading dough, carrying grocery bags. But critical caution, no resistance until the repair or healing tissue is strong enough, usually several weeks post-op.
Got it. Minimize adhesions. What about blocking exercises? How do they fit in?
Blocking exercises are another great tool, often used alongside tendon gliding. They isolate movement to a specific joint, which helps improve tendon glide across that joint and can also help stretch the joint capsule itself. You block or stabilize the joint just proximal to the one you want to move. You can use your own hand, the client's other hand, or a small piece of splint material. For example, to isolate TIP extension, you block the MP joint inflection while they actively try to straighten the PIP and DIP. To isolate DIP flexion, you block the MPIP and extension while they bend just the fingertip. Instruct clients to move comfortably to their end range, hold for maybe 3 to 5 seconds, repeat frequently but slowly. And again, think functionally. Holding a steering wheel blocks MCPs while flexing IPs. Playing guitar, sweeping, raking, these activities naturally involve blocking.
Okay, tendon gliding, blocking, general principles. How do these get adapted for specific diagnoses?
You're always encouraging gentle, full arcs of available motion unless contraindicated. Avoid quick, jerky movements. If the hand gets painful or more swollen after activity, back off temporarily. Avoid aggressive prom. Gently coax tissues, respect resistance. If passive motion is indicated, sometimes gentle joint traction, a slight pull helps. Sustained holds are better than quick stretches. Splinting choices depend on the stage. Acute inflammation. Usually a static splint in a resting, open pack position. Inflammation down, soft end feel. Dynamic splinting might be good. Hard end feel, stiffness. Serial static or static progressive splinting to apply that low load, long duration stretch. Night splinting is often great for morning stiffness and correcting tightness. Always check for contraindications before applying dynamic splints.
Right, tailor the splint to the stage and then feel. Okay, let's get into some specifics. Tendinopathy, like tendinitis or tendinosis, how do we treat that?
For tendinopathy, in the acute phase, it's often RICE, rest, ice, compression, elevation for pain. Maybe some anti-inflammatory modalities, but remember, tendinosis is often degenerative, not purely inflammatory. An orthotic might help, especially at night. In the post-acute phase, the goal is restoring function. Gradual use balanced with rest, avoiding pain. Pain-free tendon gliding. Exercises progress from isometric to isotonic. Low load, high reps, starting in short arcs, then increasing. Gentle flexibility. Aerobic and proximal conditioning are important too. Prevention is key. Teach avoidance of repetitive motions specific to their issue, like repetitive grasp release for trigger finger. Avoid stressful combined motions, like pinching with wrist flexion ulnar deviation for de Quervain's. Ergonomics is huge. Posture avoiding twisting, ergonomic tools, bilateral lifting, phone headsets, pacing. Proximal stability helps distal mobility.
Makes sense. What about lateral epicondylitis or tennis elbow?
Interventions include that proximal conditioning, scapular stabilization. A key exercise is eccentric loading of wrist extensors. Have them hold the lightweight, palm down, lower the wrist slowly, lift it back up with the other hand, repeat. A wrist extension orthosis, puck-up splint, can help at night or during heavy activity. A counterforce strap over the extensor muscles or kinesiotape can also reduce load on the tendon origin.
And medial epicondylitis, golfer's elbow. Similar but opposite.
Pretty much. Proximal conditioning again. Avoid force at end ranges. Build-up handles reduce grip force needed. Eccentric loading for wrist flexors this time, palm up. A neutral wrist orthosis or a counterforce strap over the flexor mass might help. Modify activities involving repetitive forceful wrist flexion and grasping, especially with pronation.
Got it. De Quervain tenosynovitis, that thumb side wrist pain.
For darker veins, tease them to avoid wrist deviation, especially combined with pinching. Built-up handles help. A forearm-based thumb spica orthosis, leaving the IP joint free, is crucial for rest. Check carefully that the edge of the splint isn't irritating the radial nerve area. Modify tasks. Ice. Maybe ionophoresis with the dexamethasone for inflammation.
Trigger finger, that catching or locking.
Intervention often involves splinting the MP joint in neutral. This prevents full fist making, thus stopping the triggering, and allows the tendon to glide more freely. Place and hold fisting exercises, gently making a fist without triggering, can help. Built-up handles, padded gloves, pacing, absolutely crucial. Client must avoid triggering the finger, it just re-inflames it. Ice, ultrasound might help. If they have surgery, post-op care involves early gentle mobilization, graded activity, tendon gliding activity mods.
Okay, tendons covered. Now, nerves. The nervous system interaction is so delicate. General principles for nerve injury.
After nerve injury, OT focuses on promoting functional performance, ADL training, adaptive equipment. Preventing deformity is huge. Orthotics, PROM. Education is critical. About the diagnosis, recovery sequence, nerves heal slowly, and protective guidelines for sensory loss. We constantly monitor sensory and motor changes, prevent contractures and muscle imbalance. Orthotics get modified as recovery happens or doesn't.
What about nerve compression injuries in general, like carpal tunnel, cubital tunnel?
They share common features: pain, sensory changes, numbness, tingling, muscle weakness, loss of function. The cause is usually nerve compression in a tight space due to inflammation, swelling, tissue thickening, a tumor, or pathology like RA synovitis. Conservative treatment often involves immobilization with an orthotic, either to improve circulation, wrist neutral for CPS, or just rest the area, elbow slightly flexed for cubital tunnel. Myofascial massage, nerve gliding exercises are also common. If that fails, surgical decompression might be needed.
Let's hit the big ones. Carpal tunnel syndrome, CTS.
Conservative care. Night splinting with the wrist in neutral is key to reduce pressure. Median nerve gliding exercises, differential flexor tendon gliding. Ergonomic mods, posture training. Teach avoidance of extreme wrist forearm positions, sustained pinch, forceful grip. Padded steering wheel covers, ergo keyboards can help. If it's pregnancy-induced CTS, focus on edema reduction, gloves, massage, ice. Post-operative CTS care, edema control, scar management, desensitization if needed, nerve tendon gliding. Strengthening is usually delayed about 6 weeks to avoid inflammation. Watch for pillar pain, pain in the heel of the hand, deep pressure massage. Padded gloves can help.
Radial tunnel syndrome. Pain more on the outer forearm.
Conservative, often a wrist extension splint to reduce pressure from the extensor muscles. Reduce activities with forceful resisted wrist extension grasping. Double check that a tennis elbow strap isn't actually causing the compression. Radial nerve gliding, myofascial massage. Surgery if needed.
Cubital tunnel syndrome. Ulnar nerve at the elbow.
Conservative, edema control. Orthosis or padding to protect the elbow. Positioning is huge. Avoid leaning on the elbow. Avoid prolonged, sustained elbow flexion. Increases tunnel space. An elbow orthosis holding the elbow slightly bent, 30 degrees, improves circulation, especially at night. Elbow pads, soft splints, pillows can work. Proximal conditioning, posture ergo training, all nerve gliding exercises, retrograde massage, gentle ice.
Okay. And briefly, posterior interosseous nerve syndrome. PINS. That's just motor, right?
Right. PINS affects motor function, finger thumb extension mainly. OT focuses on maintaining PROM and using orthotics to prevent deformity like wrist drop and support function.
What about actual nerve lacerations when the nerve is cut?
Repaired nerves need strict protection initially. Stress on the repair site can cause it to pull apart or form an aroma, painful nerve scar. Post-op, an orthosis limits movement near the repair. For example, digital nerve repair might have finger flexed. They can often do gentle, active passive flexion within the split to keep joints tendons moving, but absolutely no active extension that would stress the repair if the splint is off for cleaning. As healing progresses, the orthosis angle is gradually adjusted to gently lengthen the nerve. Protection usually lasts 6 to 8 weeks, then maybe an anti-deformity splint. Remember, nerves regrow slowly, maybe an inch a month. Proximal injuries take a long time. OT role. Huge emphasis on sensory re-education and compensatory techniques for sensory loss. Protect from temperature extremes, pressure, sharps. Key tip. Don't use the unaffected hand to test temperature, for the affected hand autonomic function is also damaged. Avoid heat modalities, forceful massage over the scar early on. Silicone gel can help scars. Gradually increase activity, strength, function with adaptations, avoid overstressing. Long-term orthotics prevent deformity, ulnar nerve, splint MPs and flexion, anti-clog. Median nerve, splint thumb and abduction opposition, prevent adduction contracture. Radial nerve, wrist MP extension splint, maybe dynamic suspension for tenodesis grasp.
Wow, nerve injuries require such specific, careful management. Okay, let's switch gears again. Distal radius fractures, wrist fractures. Super common, right? Fallen outstretched hand.
Extremely common. Fouche injury, fallen outstretched hand. You get Colles fractures, dorsal displacement, dinner fork look, or Smith fractures, volar displacement, garden spade. Management varies. Casting, often above elbow initially, or IF surgery, pinning. Complications are common. Arthritis, stiffness, decreased grip, carpal instability, tendon issues, nerve compression, median ulnar, and CRPS, complex regional pain syndrome.
CRPS is a big concern there. What's OT's role during the immobilization phase while they're still in the cast or splint?
OT during immobilization is critical for preventing complications. Main goals: prevent swollen, stiff fingers. Meticulous pin site care if they have external pins. Monitor cast tightness closely. Huge CRPS risk factor. Teach digital ROM, tendon gliding exercises inside the cast splint. Discourage slings, they cause shoulder stiffness. Preventing frozen shoulders, a top priority. Get that proximal ROM going. Shoulder flexion, abduction rotation. Be vigilant for early signs of CRPS. Excessive pain, guarding, autonomic changes, swelling, color temp changes. Address any tightness developing in hand intrinsics or extrinsics. Watch for tendon adherence after ORF. Blocking splints might be used during activity exercise as specific tightness develops. Differential tendon gliding is super important, frequent reps, every 1 to 2 hours. Integrate into ADLs. If extrinsic tightness persists, maybe night splinting, static progressive dynamic later on with MD, okay.
So active OT even while immobilized. What happens in the mobilization phase after the cast fixation is removed?
Post-immobilization, they often get a custom volar wrist orthosis splint for protection and to encourage extension. Helps combat that tendency to hold the wrist flexed, the doggy paw posture. Clients usually have stiffness, awkwardness, decreased function. Once cleared by the physician, start working on forearm, wrist ROM. Wean off the protective orthosis gradually. Edema control remains priority, #1. AROM and using the hand in ADLs helps pump swelling out. Guided motor imagery can be effective too. Big caution. Avoid overly aggressive therapy. Educate client family to watch for signs of inflammation, more pain, redness, warmth. Retrain specific movements. Wrist extensors separate from finger extensors. Extend wrist while making a fist. Wrist flexors separate from finger extensors. Flex wrist with fingers relax. Extensor digitorum separate from intrinsics. Extend MPs with IPs slightly bent. Gradually upgrade activities, challenging combined motions, dexterity tasks, cat's cradle, sorting laundry. Graded strengthening comes later. Once good motion is back, always monitoring tissue response.
Okay, fractures covered. What about ligament injuries, sprains, and strains?
Ligament injuries are graded 1, 2, or 3 based on severity. Grade 1, fiber stretch disrupted but ligament intact. Grade 2, complete tear of a major retaining ligament. Grade 3, complete tear of collateral ligament plus capsule often unstable. Problems: pain, decreased ROM, risk of flexion contracture. Grades 3. Joint instability, grade 3. Interventions, grade 1. Rest, thermal modalities, activity modification. Maybe a temporary orthotic. Cold for acute, heat for chronic stiffness. Grade 2. Longer immobilization than gentle protected active movement within anatomical lines to maintain flexibility without re-injury. Return to activity as pain allows. Grade 3. Often needs surgical repair. OT comes in after healing to restore functional use.
And skier's thumb. That's a specific ligament injury, right?
Yes. Skier's thumb, or gamekeeper's thumb, is usually a grade 3 tear of the ulnar collateral ligament, UCL, of the thumb MP joint from forceful radial deviation. Needs surgery. Post-op OT, protective thumb spicaorthosis, hand or forearm based, edema control. Start ROM for uninvolved joints, light ADLs. After 1-2 weeks, gentle MP joint ROM begins, progressing gradually. Address IP joint motion strength too. Resistive exercise starts around 6 weeks, pinch strength comes later, tip pinch maybe 12 weeks. May need the spica for protection during heavy activity even longer. Scar hypersensitivity near the radial sensory nerve is common, needs desensitization.
Okay, ligaments done. Let's talk tendon injuries generally. Flexors and extensors seem vulnerable.
Very vulnerable. They're superficial, easily cut or ruptured. They lack bulky muscle in the hand itself, gliding precisely through sheaths balanced by intrinsics. They also have limited blood supply. This means scar tissue is a huge problem, significantly impacting mobility. Scar management and tendon gliding are paramount.
And flexor tendon injuries.
Yeah.
You mentioned zone 2 being no man's land. Why so tricky, and what are the rehab protocols?
Zone 2, from the distal palm pulley to the middle phalanx FDS insertion, is tricky because both flexor tendons, FDS and FDP, run together within a tight sheath system. Repair is technically challenging, adhesions are common, and historically, outcomes were poor. Flexor tendon surgery is complex, often involving tendons, pulleys, maybe nerves and arteries. Prognosis depends on many factors. Protocols have very specific precautions. Post-op goals: protect the repair, allow controlled tendon glide, limit rupture risk. OT uses controlled mobilization protocols, usually with a dorsal blocking orthosis, wrist flexed, MPs flexed, IP straight, unless nerve repair needs flexion. Common protocols include Duran protocol. Therapist or client performs passive finger flexion extension within the splint. Aims for minimal tendon glide. Gentle active motion starts around 4 weeks. Kleiner protocol. Uses rubber band traction from fingernail to forearm. Client actively extends fingers against rubber band passively flexes them back. Prevents active flexion early on. Digits might be strapped down at night to prevent contractures. Chow protocol. Combines elements of both. Early active motion. Newer protocols, possible with stronger suture techniques for good candidates, allow very early controlled active flexion. General progression. Active flexion usually starts around 4 to 6 weeks, gradually increasing until full function, maybe 12 weeks. Ongoing focus: edema, scar management, tendon gliding, place and hold exercises, corrective splinting, ADLs, graded activity exercise.
Okay, flexors are complex. What about extensor tendon injuries? Are they simpler?
Sometimes considered simpler, but still require precise management. There are 7 zones over the finger shank, 5 over the thumb. Zone 1 or 2, mallet deformity. Terminal tendon disruption of the DIP joint, causing DIP extensor lag. Fingertip droops. Non-surgical, continuous splinting of the DIP and slight hyperextension for 8 weeks, PIP joint free. OT makes custom orthosis or fits prefab. Instruct on use, skincare. AR-ROM-PROM further joints. Post-splinting. Gentle active flexion, balance with active extension. Watch for lag recurrence, resume splinting if it happens. Orthosis often continued at night between exercises for a while. Zone 3 or 4, boutonniere deformity. Central slip injury over the PIP joint, causing PIP flexion, DIP hyperextension, lateral band slip volarly, non-op, splint PIP in full extension for 6 weeks, allow encourage active-passive DIP flexion. Operative. Follow surgeon's protocol. Watch for PIP extensor lag when active motion starts. Zone V6-7, over back and hand rest. Management varies in mobilization or controlled early motion. Adhesions are common, especially zone 7 over the wrist retinaculum. Close communication with the surgeon is essential for protocols orthotics.
Excellent breakdown of specific interventions. To wrap this section up, let's look at that final case study. Sage, the 31-year-old new mom with Dicker veins. How did OT apply these principles?
Sage's case is a classic Dick Revane tenosynovitis presentation. Medical diagnosis confirmed she had a corticosteroid injection. Referral to OT was for childcare ADL issues and a thumb spica orthosis.
What did her occupational profile reveal?
Significant pain impacting infant care, lifting, bathing, dressing baby, car seat, self-care fasteners, cooking. Partner helped, but she felt overwhelmed. Didn't understand cause or modifications. No orthosis yet.
And assessment findings.
Pain 410 rest, spiking to 910 with activity. ROM limits consistent with Dick Revane's. Reduced wrist flexion extension, radial under deviation. Thumb MP flexion severely limited. Swelling tenderness over first dorsal compartment. APL, EPB tendons. Bruising from injection.
Clear problem list matching her concerns. What about goals?
Goals were very functional, directly tied to her roles as a mother and individual. 1. Pain-free bathing dressing car seat use within 2 weeks. 2. Modified independent self-dressing fasteners within 2 weeks. 3. Pain-free family meal prep within 2 weeks.
Perfect. How did intervention address these?
Started with fitting a prefabricated thumb spica orthosis instructed for intermittent use during resistive tasks, decreasing use as pain improved. Gentle AROM for wrist and thumb within pain limits. Therapeutic ice. Gentle retrograde massage for swelling pain. At the 2-week follow-up, they reviewed ergonomics for childcare lifting techniques, positioning, emphasized avoiding resisted ulnar deviation and forceful pinching with the thumb, suggested built-up handles for cooking, instructed to return to full-time splint cold if pain flared up. Results were great. ROM normalized, pain down to 210 with activity, 010 rest. Shows how targeted intervention orthosis, exercise, education, ergonomics can quickly impact function.
Fantastic illustration. And underpinning all these interventions is evidence. How do the studies highlighted in our sources validate what we've discussed?
The evidence really supports many of these approaches. For instance, a high-level RCT showed integrating OT into hip fracture rehab improves emotional distress, fatigue, and function long-term. Validates our holistic approach. A study on total shoulder arthroplasty showed it improves ROM and EDL performance, supporting our rehab goals there. Interestingly, for rotator cuff tears, one RCT found standardized home exercise programs could be as beneficial as supervised OT for many outcomes, highlights the power of good client education and home programs. Another RCT showed early postoperative OT after hip fracture sped up ADL recovery at discharge direct functional impact. Prevention works too. An RCT on ergonomics joint protection for RA showed fewer hand deformities and better ADL scores years later. Huge long-term benefit. Reviews suggest wrist splints for RA help pain and grip. Exercise for hand OA likely improves pain, function, stiffness, grip. And assistive technology for hand OA definitely improves performance and satisfaction. Even specific techniques like eccentric training for lateral epicondylitis have evidence supporting their effectiveness for pain and function. These studies, across different levels, basically confirm why we do what we do. They provide that critical link between the classroom theory and what you'll be applying effectively in field work.
What an incredibly comprehensive journey. We've really gone from the foundations of OT and orthopedics through detailed evaluation into the specifics of fracture shoulder, elbow, wrist, then chronic conditions like RA and OA, and finally, a deep dive into interventions for everything from edema and scars to tendons, nerves, ligaments.wu. It really underscores that holistic, occupation-focused approach.
Absolutely. This deep dive should give you a really solid foundation as you head into your Level 2 fieldwork. You've got the overview of assessments, guidelines, interventions, diagnoses. But remember, this knowledge is your starting point. That true clinical mastery, the reasoning, the adaptability, connecting with clients that comes from the hands-on experience, from thinking critically in the clinic every day. Embrace those learning opportunities.
Definitely. And as you step into that clinical world, thinking about the hand, how intricate it is, how deeply tied to everything we do, here's a final thought to mull over. Given that complexity and personal significance, how might your unique perspective as an OT unlock even more creative, client-centered solutions, going beyond the protocols, always keeping their meaningful activities right at the heart of your practice? Go out there and make that difference.